I'm Dr. Robert Jones, and in this lecture we're going to go through how to perform the transthoracic windows of the focused echo exam. Let's look at the exam essentials. From a patient positioning standpoint, usually the exam is initiated with the patient in the supine position. However, at times this may not allow for adequate visualization of the heart, so turning the patient into the left lateral decubitus position may be required. From a transducer standpoint, use a 2 to 5 megahertz small footprint curvilinear or phased array transducer. Avoid the large footprint curvilinear transducer since you're going to end up with a lot of rib shadows with that transducer. And from a patient preparation standpoint, there is no specific preparation required. Images in this lecture will be shown in the cardiac orientation. Some of them will have been obtained in the abdominal mode versus cardiac mode. However, from an imaging perspective standpoint, all the images will be shown in the cardiac orientation. Here we have a subcostal window. This one was obtained in the abdominal mode. You can see that the indicator is directed towards the patient's right. If we were in the cardiac preset, the indicator would be directed towards the patient's left. The image that you see here is, you've got the transducer here, which is anterior and inferior. You're aiming posterior and superior. You've got patient's right, patient's left. You've got the liver here as a window. You've got the right ventricle, left atrium, and right atrium, and you'd be looking here for the surrounding pericardium and for any evidence of fusion. It's important that you give yourself enough field of depth in order to visualize the entire heart, and you have to make sure that you've got the transducer in the subxiphoid space underneath the xiphoid process so you get good visualization of the heart. Now, the subcostal window is going to provide a nice 4-chamber view of the heart. It'll give you the ability to evaluate for RV and LV systolic function globally. It'll allow you to evaluate the septum, and it's going to allow you to evaluate for the presence or absence of pericardial effusion and or tamponade physiology. Having the patient take in a deep breath can significantly aid in visualization of the heart. Here you've got a nice 4-chamber view of the heart. You can see the liver is a window here, so you've got right ventricle, left atrium, right atrium. And you can see that as the exam started off, there was very little visualization of the heart noted. However, when the patient took in a deep breath, and that's all that was done here, you end up with a nice 4-chamber view of the heart. So as it starts off here, you don't see the heart, but as the patient takes in a deep breath, now you've got a nice 4-chamber view. So keep that in mind when you're doing the subcostal window. If you don't see what you want, have the patient take in a deep breath. Now be careful about measuring the RV and the LV from this subcostal window, because depending on how you have the transducer angled from one side to the other, you're going to either emphasize or de-emphasize the left or the right side of the heart. So it's possible that you could overestimate the right ventricle or underestimate it by how the transducer is angled. So you can see here, at one point the RV looks enlarged, but we're off axis here and rotated, but then in the beginning we rotate it and de-emphasize the RV. So just be careful when obtaining RV, LV measurements from this window. Of the transthoracic windows, usually the parasternal long axis is the first one that's performed. And this is basically a long axis cut through the heart. The transducer imaging plane is from the right shoulder to the left hip. If you are in the cardiac mode, you want the indicator pointed towards the patient's right shoulder. If you're in the abdominal mode, you're going to want the indicator pointed towards the patient's left hip. Here we've got the following image then, and this is from the cardiologist perspective. You've got anterior, posterior, foot, and head. This is an opposite long axis imaging perspective from when we scan in the abdomen, but imagine that you're looking at the heart from the patient's left side. So you've got the right ventricle here, left ventricle, left atrium. You've got the aortic outflow tract here. Here you've got the descending aorta, And this patient has a small pericardial effusion, and you can see that it goes in between the back wall of the heart and it's anterior to the descending aorta. Let's use this three-dimensional view of the heart from a CAT scan to show how the echo window is obtained. So you're basically, with this window, going to make the cut from right shoulder to left hip, and what that's going to then give you is the following view of the heart. We'll just rotate it here. And this is going to be the echo window that we're going to be using. Right ventricle, left atrium, aortic outflow tract. Here's descending aorta here, so the orientation is going to be anterior, posterior. This is going to be caudal, and this is going to be cephalad. Here we can compare the anatomy from the CT scan to an actual ultrasound. So again, right ventricular outflow tract, left ventricle, aortic outflow tract, left atrium. Here's the descending aorta, and here's the descending aorta. So overall orientation is going to be anterior, posterior, caudal, cephalad. So overall, the parasternal long axis will allow you to visually estimate global LV function. It's going to allow you to evaluate the mitral and aortic valves. It'll allow you to evaluate RV free wall function, and it'll allow you to evaluate the patient for the presence or absence of a pericardial effusion. The parasternal short axis window is going to be an imaging plane obtained from the left shoulder to the right hip. If you are in the abdominal mode, you're going to place the indicator towards the patient's right hip. If you're in the cardiac mode or cardiac preset, you're going to have the indicator pointed towards the patient's left shoulder. And this will provide you with the following image: anterior, posterior, patient's right, patient's left. Here's right ventricle, here's left ventricle, and this is a patient that had a large pericardial effusion surrounding the heart. Now with the parasternal short axis window, you can obtain this at multiple different levels. Here on the right, we're at the level of the aortic valve. On the left here, we're at the level of the mitral valve, and here you can see the right ventricle, and here you can see the left ventricle with the mitral valve right here. Now the apical four-chamber is a nice four-chamber window. This one is going to be obtained with the transducer at about the level of the PMI, and if you are in the abdominal motor preset, your indicator is going to be pointed toward the patient's right. If you are in the cardiac motor preset, your indicator is going to be pointed toward the patient's left, and this will provide you with the following view. This was a patient with a very large pericardial effusion, but here you can see the heart and you can see the four chambers. You've got right ventricle, left atrium, and right atrium. So this is going to be caudal, cephalad, patient's right, patient's left. So here's a comparison of a CAT scan to the ultrasound. So here you can see right ventricle, left ventricle, left atrium, and then right atrium, and right atrium right here. Now the apical four-chamber will allow you to evaluate both right ventricular and left ventricular function. It'll allow you to evaluate the heart for the presence of a pericardial effusion and or tamponade physiology. It's going to allow you to evaluate the tricuspid and mitral valve, and it's going to allow you to compare RV to LV size. Now this concludes the transthoracic cardiac windows video. I'm Dr. Robert Jones, and in this lecture we're going to go over how to visually estimate global LV function. Global LV function can be determined by visual estimation, and for the sake of what we're doing, I would recommend categorizing it as either hyperdynamic, normal, or moderate to severe dysfunction. You're going to evaluate the endocardial border excursion towards the center of the LV, and you're going to look for increasing wall thickness during contraction, and you obtain as many windows as necessary. When you're at the extreme, basically dealing with either normal or a severe dysfunction, you probably could obtain accurate information with just one window. But with lesser degrees of impairment, it may require you to look at the heart from more than one window. The evaluation of global LV function can be helpful in making therapeutic decisions for the unstable critically ill patient. These findings are used in conjunction with the inferior vena cava dynamic assessment. This will give you an idea as to overall LV volume status and function. Particularly in patients who have never been to your institution before and there's no prior records of cardiac status, it can be immensely helpful in these critically ill patients to know what their global LV function is and what their inferior vena cava assessment is. This can give you a wealth of information in terms of whether or not to give fluids and potentially how much fluid to give. On the subcostal window, look at the endocardial borders. I think it's helpful to use a tissue harmonics function so that you'll be able to better observe the endocardial borders. You're also going to want to take a look at the mitral valves and tricuspid valve to make sure that they're opening fully, but this is a patient with a normal LV function. And here's a patient with severe global LV function or dysfunction. If you take a look, just to the naked eye, the patient has enlargement of the cardiac chambers, and what you also see is that there is very little to essentially no movement between systole and diastole. This was a patient who, by calculation, had an ejection fraction of 10%. Now, this is a patient that is relatively apparent on one window. For the sake of a focused echo, you probably don't need to do additional windows to confirm that this is severe dysfunction. So here's a comparison of normal. You can see the difference in the endocardial borders here between systole and diastole. You can see nice opening of the mitral valve and the tricuspid valve here as compared to this patient who, looking at the endocardial borders, has very little difference between systole and diastole and has very sluggish opening of both the mitral and tricuspid valves. Here's an older patient with underlying history of hypertension and cardiac disease who came in with a massive GI bleed. If you take a look at this patient's LV function on the subcostal window, you can see that the endocardial borders are dramatically changing between systole and diastole, and they're almost opposing at end systole. Some refer to this as the kissing ventricles. This was a patient who had hyperdynamic LV function. Here's another patient with hyperdynamic LV function who was profoundly septic. You can see the LV here on this subcostal window, and you can see that at end systole, the walls are almost opposing. There's very hyperdynamic function here. We have a subcostal window of a young, otherwise healthy male who had sustained multiple gunshot wounds and had massive hemoperitoneum. This study was performed to look for the presence of hemopericardium since the patient had several gunshot wounds to the chest. There was no hemopericardium noted. There is some fluid in the peritoneal cavity noted, but no pericardial effusion or tamponade. But what we did notice when we looked at the heart is that it was hard to even see the chambers on either the right or the left, and that's because the patient was so volume depleted. And here you can see essentially kissing ventricles on both sides, and this was a patient who's hyperdynamic and was severely volume depleted. So here's a spectrum of severe dysfunction, very little change in the endocardial borders from systole to diastole. This was a patient with the EF of about 10%, to here's a patient with a very hyperdynamic LV, and you have basically the complete opposition of the walls during end systole, or the kissing ventricles. This is a patient with severe hyperdynamic LV dysfunction, or LV function. Let's look at the parasternal long axis window. Here's a patient with normal LV function. So again, you're going to want to look at the endocardial borders. You're going to want to observe for increased thickening, as you see here during contraction, and you're also going to want to look at the mitral valve and the aortic valves. With normal LV function, you should see, in the absence of any underlying valvular disease, you should see that the anterior leaflet of the mitral valve will touch the septum up here. Here's a parasternal long axis window in a patient with severe LV dysfunction. This patient's EF was 15%. So you can see that there's chamber dilatation here. It's globally enlarged, and you can see that there's really no change in the endocardial borders between systole and diastole. And you note here that the anterior leaflet of the mitral valve does not reach the septum. So this was a patient with severe LV dysfunction. Now here's a patient looking at the parasternal long axis who's got hyperdynamic LV function. This was a patient who had a massive GI bleed. So you can see that, looking at the endocardial borders, there's significant variation between systole and diastole. They're almost opposing or kissing here. And this was a patient with normal LV function. And again, you can see that there is, adequate change between systole and diastole. You're following the endocardial borders. You can see that there is thickening of the wall during contraction, and you can also see that there is brisk opening of the anterior leaflet of the mitral valve, and it does touch the septum. Here's a normal parasternal short axis window, and again you're going to evaluate the endocardial borders during contraction, and you're going to look for wall thickening during the contraction, and you can see that there is adequate variation between systole and diastole. This was a patient with normal LV function. Let's look at the spectrum on the parasternal short axis. Here you've got somebody with severe dysfunction. You can see here's the LV, here's the RV. Both are dilated here. And you can see that there's very little change in the endocardial borders between systole and diastole. However, in this patient who was extremely hyperdynamic, you can see that there is a significant variation of the endocardial borders between systole and diastole, and they're almost opposing each other or kissing. So this was a patient that had a significant GI bleed. Here's a normal apical four-chamber window. You can see the RV, RA, LV, LA. You can, on this window, compare RV to LV size, but right here, for just determining global LV function, again, you're going to look at the endocardial borders, you're going to look for the change between systole and diastole, and you note that there is adequate change here. The walls are not completely opposing or touching, there's no evidence of a hyperdynamic state, and you can see that there is brisk opening of the leaflets of the mitral valve and the tricuspid valve. Let's look at the extremes of function on the apical four-chamber window. Here you've got somebody with an EF of about 10 to 15%. Note that there's really no thickening of the wall during contraction, and that there's very little variation between systole and diastole of the endocardial borders. Also note that the mitral valve and tricuspid valves are not opening up briskly, as opposed to this patient who had severe hypovolemia. Note that there is increased thickening of the LV walls during contraction. Note that there is a very great difference between the endocardial borders between systole and diastole. Note that they're essentially opposing or kissing. This was a patient who had hyperdynamic function due to severe hypovolemia. Let's briefly go through Takotsubo's cardiomyopathy, which is transient apical ballooning. Some call this broken heart syndrome, but this is basically transient hypokinesis of the left ventricular mid-segments with or without apical involvement. And the regional wall motion abnormalities are going to extend beyond a single vessel distribution. In order to make this diagnosis, there should be absence of obstructive coronary disease or angiographic evidence of acute plaque rupture. There may be EKG changes that mimic acute coronary syndrome. You should also have absence of pheochromocytoma or myocarditis prior to making the diagnosis. And here you can see in this patient with Takasobu's cardiomyopathy that there is apical ballooning here, and you can see that there's good function up until about this point in the mid-segment on both the right and the left, and you see very little function down here by the apex. This was a patient who had Takasobu's due to pneumonia and sepsis. And here you can see a follow-up echo of the patient 5 days later, where you start to see now that there is return of function down by the apex here. And here the patient was on day 1, where there was essentially no contraction by the apex here, and you had the apical ballooning. Focal wall motion abnormalities require a much greater degree of expertise and training in order to interpret, and there's variability in interpretations even with experienced cardiologists, so therefore this is not going to be a part of the focused echo that we're covering in this lecture. However, with that being said, I just want to throw out a case here where, even though it was not the goal of the study to determine the presence or absence of a focal wall motion abnormality, this was very glaring and stood out. This was a patient who came in after being resuscitated from a cardiac arrest. When he came in, he had ACLS continued, and we did a focused echo to evaluate for potential pericardial effusion or tamponade, as well as to look for evidence of RV strain and to see global LV function. What we noticed is that along the anterior wall here, the LV, there's essentially no function, but there's good function along the posterior wall. So it clued us in that there was a significant focal wall motion on this patient. And the EKG, which was done shortly after, supported our findings. This was a patient with a very large anterolateral myocardial infarction. This now concludes the LV function lecture. I would advocate that you scan as many hearts as possible, both those with normal function, those with hyperdynamic function, and those with known chronic severe dysfunction. This is the way you're going to be able to adequately in your mind determine visual estimation of LV function. So scan as many hearts as possible.